think we are ready to rock and roll. You should be seeing the right screen. Andrea, are we good?
We are good.
Fantastic. Okay, I'd like to welcome everyone to the University of Texas MD Anderson Cancer Center Integrative Diagnostic Medicine Case Conference for December 4. Let's see. Also subtitled Adventures in Neuro-Oncologic Diagnostic Medicine. I think we're going to have a lot of fun at this conference. It's been, what, 2 weeks, maybe 3 weeks, because we had the Thanksgiving break. So I hope everyone is ready to go. Let us see here. H&E warm-up. We always do warm-ups, and I think we're going to need to do that in this case. So here is the warm-up. And what do you think is going on here? It's an interesting warm-up, isn't it? Almost like a Rorschach. You know, you can see shapes and patterns. Let's back out just a little here to see what type of preparation do you think is going on here? All right, this is a CUSA. So this is cavitational ultrasonic surgical aspiration, and you know that because of the bubbles in blood, and I've circled the areas here, so that is showing that it is CUSA. All right, and I want to focus on this high power, and the question is, what is your differential diagnosis? And what we're actually looking at here is a specific slide setting. Okay, hang on just a second. I gotta get back down here. For some reason, the chat box has disappeared. I'm not gonna be able to hear your chats. Oh my goodness, that's terrible. Let's see here. How can I do this? Oh, well, you know, the best laid plans. Let us see. Okay, I'll tell you what. Stop share. How about we escape? All right, go down here. And oh, here we go. Here we go. I need 2 participants. Let's see. I already have that. What I need is, I need chat. You know, every time I do this, it is a brave new world. And because I'm working with a single screen, okay, let's do this. I'm going to pause it for a second.
Dr. Fuller, you're muted.
Okay, how about now? Okay?
We can hear you now, yes.
Okay. And are you seeing the presenter screen? Probably.
We're seeing 2.
Yeah, that's a presenter screen. Okay, hang on just a second. Let me swap them. Okay, how is that?
That looks great.
Okay, I'd like to welcome everyone back to the conference. Let's see here. Okay, let's fast forward to where we were. Yeah, you know what? I think I'm not going to be able to see the chat function. Not sure why. It doesn't matter. I think I'm going to allow everyone to unmute. All right. So, and I saw that there were comments. So we're going to have to work it that way. All right. Differential diagnosis. I think I saw a comment, medulloblastoma. I like that because what you're seeing is the smear artifact. All right. For differential diagnosis, medullo's good. So small cell neoplasms tend to smear easily. All right, so let's go and let's look at some of the areas where it is less distorted. So you can see the swath in the middle of undistorted tumor. Here we go. A little bit higher power. And I wonder, what do you think about this? Anybody want to unmute? Maybe up to Andrea and Zainab to voice, to speak for the group. All right, so you guys are under the gun, right?
Small round blue cell tumors.
Okay, I like it. Very good. How about this? How about this? We still at small round blue cell. See any patterns? Any patterns?
Rosette.
Nope. Thank you very much. Differential diagnosis. Small round blue cell tumor with rosettes. Okay, very good. How about this? Let's go to the imaging. Okay, now I've just given you a huge piece of information. Intraventricular tumor. And we're looking at CT, so we're going to go with the CT scan. All right, and here's a sagittal. And what we see here on the coronal is that the tumor is involving lateral ventricle at the foramen row, going from lateral ventricle into the third ventricle. And there's pretty much only one tumor that should be at the very top of your differential diagnosis, and that is going to be central neurocytoma. Everybody on board with that? Okay, here we go. Diagnosis, and that's it. Central neurocytoma. Right, and WHO grade 2, quick question. Why WHO grade 2 for central neurocytoma? Well, and the answer is this. Here is the problem. What you can see is these little nodules lining the ventricle and the septum pellucidum. That's why central neurocytoma, which is a very low grade tumor in terms of mitotic activity, is a grade 2 and not a grade 1, is because of the very high incidence of recurrence. All right, let's do an MRI warm-up. That was really a CT warm-up. We need to do an MRI warm-up. All right, I'm gonna call this bread and butter. All right, bread and butter. And let's go, which means you need to be familiar with the types of, we'll call it situations that you encounter routinely, right? That's basic. All right, we'll have a look at this. And what you can see is a left-hand panel's T2 and a T1 with contrast on the right, axial scan. So what diagnosis does this suggest? And I think schwannoma, very good. And let's look at a couple of T1 post-sagittals. And I'm gonna highlight here for any of the beginners. This is a critical, what's happening here in this particular area. This is showing involvement of the internal acoustic canal. All right, very good. So would you like to see the histology? Let's have a look at the histology. What do you think? Is this the whirling variant of vestibular schwannoma? And this is a Ki-67, by the way. You know, I didn't have an H&E to show you. Unfortunately, no H&E to show you. This is a Ki-67. Ki-67 has a hematoxylin background. You can see morphology just as well, patterns on a hematoxylin only as you can on an H&E. To an experienced oncologic surgical neuropathologist, it doesn't matter really that much if it's an H&E or a hematoxylin, you can see it. All right, these are clearly whorls. Look at that. Is that magnificent or what? This is clearly a transitional meningioma. All right, quite beautiful. So what we have here is an example of cerebellopontine angle meningioma mimicking vestibular schwannoma. All right, let's look at the neuroradiology report. Left cerebellopontine angle, enhancing mass, extending into and widening the porus acousticus. Absolutely, remodeling the porus. Statistically, this most likely represents a vestibular schwannoma. So look, here's the thing. Dr. Gilbert said schwannoma, and that is exactly the correct thing to say in this instance, without a doubt, as in this report by an experienced oncologic neuroradiologist. Statistically, this is a vestibular schwannoma. However, given the presence of adjacent enhancing dural tail, I'll show you in a second, and suggestion of possible adjacent cortical hyperostosis, which would not be seen, would never be seen, never say never, I'm gonna say never, in vestibular schwannoma, meningioma is included in the differential consideration, all right? Here's an example of what I didn't show you, because I wanted to show you exactly what was leading to this major impression. Can you see the dural tail there? That's magnificent. Okay, Forkey asks a question. Forkey has a question. Forkey's question is, can vestibular schwannoma ever present with a classic dural tail sign? Well, you know, the answer to this type of question is always, of course, yes. Well, look at this. Google Scholar took, was it 0.06 seconds to turn up 1,350 papers. Now, I did not look at all 1,350 papers, but look down this list of just the top hits: the dural tail sign, vestibular schwannoma, acoustic neuroma. Every single paper of all these listed here are talking about the differential diagnosis of a dural tail beyond meningioma. And the answer is absolutely. Let's just look at one. Okay, let's go way back to my second year at MD Anderson Cancer Center as a faculty member in 1993. Dural tail adjacent to acoustic neuroma on MRI case report. And look at that. You see the panel on the right, T1 contrast? That is a drop dead, gorgeous dural tail, spherical tumor, et cetera. And this was vestibular schwannoma, well recognized. Now, the point of putting this case in is there is always a differential diagnosis, always. And there is a big peril, a big trap of making an instant snap judgment diagnosis and moving on. And the problem is not making the snap judgment, the gestalt, that's fine. The problem is, and then moving on without further considering, without putting your hypothesis for what you think the diagnosis is. And this doesn't matter if you're diagnostic neuroradiologist or diagnostic surgical pathologist, you need to always step back and test your hypothesis, critique your own hypothesis, put it in the crucible. See if there's any weakness, right? Compare it against the 8 Venn diagram spheres, all right, and the differential diagnosis, and see if there's any weakness. This is a beautiful imaging report. Statistically, this is still most likely, based on the imaging alone, to be vestibular schwannoma. Yes, with the dural tail, which the neuroradiologist signed this out was very familiar with, all right? No weight of evidence. That's why, listen, that is why we always have a differential in radiology as well as pathology. In this case, it was the second entity on the list. It was a meningioma, right? Doing the mimicry. And that's why, listen, remember that 8 Venn diagram sphere, age, gender, anatomic location, imaging characteristics, molecular signature, differentiation organ. That's why we have 8 spheres, is to protect us. Listen, to protect us from looking at a case like this and just saying, oh, vestibular schwannoma, bam, next case, right? Totally wrong, 100% fail without including the differential diagnosis. Did you like that? This is a lesson for all of us. And that's why I set the little traps, right? Because everyone can fall into them. Okay, hey, that was a lot of fun. Let's do MRI warm-up number 2. All right, still not warm enough. All right, have a look at this differential diagnosis. And what I'm showing you here on the left, axial T1 with contrast, and on the right is a T2, native T2. And you can see what appears to be a large ring enhancing cystic mass lesion. And then I will ask differential diagnosis. Actually, let's go back. Sorry, that was too fast. Differential diagnosis. Differential diagnosis in this case, you should be thinking, look at that smooth, even rim. The diameter of the rim is even all the way around. You have to include pyogenic abscess. It's a little wavy. I agree that's a little bit, it raises a question mark, a little doubt, but you have to put in pyogenic abscess, and then we'll put in metastasis, obviously cystic metastasis, and you have to put in cystic glioblastoma. Remember that. We cover it periodically in this conference. Reiteration is good. All right, until you've seen at least a dozen cystic glioblastomas and accurately included them in your differential diagnosis and then been correct, then until that point, everyone in the conference, we're going to keep presenting them. Does that make sense? Okay, and now the new information and what you're seeing here, I know all the neuroradiologists, experienced oncologic neuropathologists know what's going on here. Diffusion weighted imaging on the left and the ADC map on the right. It is not restricting diffusion. All right. Therefore, I can ask, what is your diagnosis? And there's one diagnosis that you can give fairly confidently, not 100%, nothing's 100%. How about not pyogenic abscess? Or let's say highly unlikely to be pyogenic abscess. So just by looking at the DWI and ADC. Now, if that DWI, if that dark area had lighted like a light bulb, glows like a light bulb, like the sun, all right, and the ADC map confirmed it by going dark, so it's not T2 shine through, then we would have moved pyogenic abscess, bacterial abscess, to the top of the list. But that is not the case. So what we are left with is cystic metastasis and cystic glioblastoma. And this was a case of cystic glioblastoma. So the final point right here, listen, the final point here, the point of this case, the only point of this case was I give you a cystic rim enhancing mass lesion. I just wanted to make sure that in your differential, you included cystic glioblastoma. If cystic glioblastoma was not in your differential, not at the top of the list, if it was not in your differential, you're not yet an oncologic neuropathologist or an oncologic neuroradiologist. But there is hope. Keep attending the conference. Okay, let's go again. Let's do another warm up. It is really cold today. I don't know. I know people attending this conference are all over the world. I know back down in South America it should be warm, right? This is a time. Well, we were freezing here. It was absolutely freezing. I think it got down to 40. Okay, someone silenced that. I don't know what that was. Okay, here we go. MRI. Now we're going to put a spin on this. You ready? We're going to do speed drill, and I want a diagnosis. All right, so we're going to do a speed drill. So what that means is you could use it. I said use the chat box. Now I can't see the chats. Here's the thing. That's okay. It's honor system. I think you guys can probably see each other's chats. That is good enough. Sorry, I can't give you public recognition. Not to give you public recognition for getting things right. I want to give you public recognition when you fail, so you're humiliated in front of an international audience, so you don't forget it, right? That's always the point. Okay, that's okay. All right, honor system. Here we go. Speed diagnosis. How quickly can you get it? All right, and it doesn't matter. You just think about it. All right, you ready? Here we go. Diagnosis. Okay, that should have been long enough for you to type in the abbreviation for the diagnosis. There's always a differential. There is always a differential. I will accept anything within the differential, but there's one entity that really should be on the top of your list for this imaging appearance. Maybe this makes it a little bit easier. Okay, so what I showed you was the T1, and now here's the T1 with contrast, and you can see how this boxcar lesion, the very top part of the lumbar cistern there at the transition between conus medullaris phylum terminale, homogeneously strongly contrast enhancing. What I was looking for is MPE, myxopapillary ependymoma. Other entities in the differential diagnosis, paraganglioma of the phylum terminale, schwannoma, meningioma, but particularly the clear cell subtype, solitary metastasis, fine. And there's issues with each of those, et cetera, but MPE has to be one of the first things that you think about with this. And I just wanted to see how quickly you could identify the lesion on a T1 when it was really hypo-intense, okay? All right, and let's look at the histology. Well, even at low power, you can appreciate the perivascular pseudorosettes. All right, go to a little bit higher power, and that's a beautiful perivascular pseudorosette, looks like ependymoma. Look at the nuclei. You see the nuclei? These are ependymal nuclei, and it doesn't matter if it's myxopapillary ependymoma or clear cell ependymoma, any kind of ependymoma, the nuclei are always the same. Number one, they're very monomorphic. And the difference between ependymoma nuclei and, let's say, the nuclei of oligodendroglioma or central neurocytoma, which are also very monotonous, is oligos in central neurocytoma, the nuclei are monotonously strictly round, spherical. These nuclei of ependymoma tend to be more oval. So if you just take a minute, just look at representatives. There are some that are, I agree, very round, but they're not as round as central neurocytoma or oligo, and they tend to be more oval. So I say round to oval and very monotonous. And that's giving you a clue, listen, a clue that this is probably ependymoma and not, say, astrocytoma. Ependymoma, not astrocytoma, if that was in your differential diagnosis, because this would be a very monotonous astrocytoma, diffuse astro of this cellularity. At this cellularity, you would tend to have more pleomorphism. Okay, that's just another little minor point. And then this was from the lower half of the big piece of tissue we saw. There are the highly characteristic mucinous microcysts, and the cuffs, the perivascular cuffs, are also accumulating mucin. Now, I've said this many times before. Myxopapillary ependymoma. Number one, the papillary is a misnomer. It's not papillary. It is not papillary intradural. It is not papillary. I know it's in the name. They are, listen, they are papillary when they arise in the soft tissue, right? Either the dorsal soft tissue, lumbar region, or retroperitoneal anterior, all right, to the sacrum. They are papillary. They grow in a papillary pattern, but not here intradural. Secondly, myxopapillary. The myxo is highly variable. It is most common to have a lot or prominent amount of myxoid material in two anatomic locations, in microcysts, which are rimmed by the tumor cells, the ependymoma cells themselves, and in the perivascular anuclear cuffs, the perinuclear pseudorosettes, which are the cell processes of the ependymoma cells. The mucin tends to accumulate between the processes, all right, in these perivascular cuffs, those two compartments. That is most common. However, there is a spectrum of the amount of mucin in some examples. Listen, some examples of myxopapillary ependymoma do not have any myxo. Or it can be so focal you have to search for it, but they are in the characteristic anatomic location, which means arising from the phylum. They look like a boxcar, the whole same thing, and the behavior is going to be identical. Everybody got that? That's just being familiar with the spectrum. In other words, all we're saying, another way of saying is, do you have to see Samoma bodies, whorls and Samoma bodies to diagnose a meningioma? If that's the case, then you're never going to make the diagnosis of syncytial or microcystic or these other variants that don't have whorls or Samomas. We're talking about the spectrum morphology. Okay, here it is, myxopapillary ependymoma, and notice that we have already updated to the forthcoming 5th edition. Okay, I think everyone knows by now it's not going to be the WHO 2020. It's going to be the WHO 2021. All right, everything takes longer. The final stages of editing is ongoing. It will be soon, but we can call it the WHO 2021 at this point. Notice we are adopting 2 conventions there. Number one, a big deal. We're raising the grade of myxopapillary from a 1 to a 2. Okay, because the clinical behavior, and that is frequent recurrence, even in cases that appear to be gross totally resected. This is why the standard of care is to irradiate, radiation therapy for all resected myxopapillary ependymomas, even if it appears to be a SNP, gross total resection, still radiation therapy, because there could be micrometastases, which are not seen even by the neurosurgeon using the loops. So grade 2. Secondly, the Roman numerals in oncologic neuropathology, WHO grading are gone forever. It's Arabic. You might as well switch now, get ahead of the curve. All right. Well, it was so cold in Fulshire today, right? Out where I live, we call it Houston, South Texas. So cold. We're going to do one more MRI warm up, and let's make it another speed drill. I like the speed drills. They're great, aren't they? Okay, you ready to go? You can just do this in your own mind, or you're going to chat if other people see your chats. Ready? All right, here we go. Diagnosis. What's a diagnosis? Okay, and here we go. Even go CT on the far left, T2 star gradient echo. All right, you know what I would accept here? Probably the best diagnosis would be hemorrhagic lesion, or how about this? Fluid level, blood fluid level, or hematocrit level. This is a hemorrhagic lesion. That would probably be the best. If you want to make a specific diagnosis, knowing that all of these cases are coming from MD Anderson Cancer Center, you would probably guess a hemorrhagic neoplasm. For the most common are going to be metastases, hemorrhagic metastases. And of the hemorrhagic metastases, melanoma is one of the first that comes to mind. Renal cell goes more frequently to bone than brain, but it absolutely goes to brain. We see a lot. It also could be hemorrhagic. Choriocarcinoma, we always put in choriocarcinoma, but it's such a rare tumor, and metastases to the brain are well recognized, of course, but really rare. I'm trying to think, okay, this past year, I've saw maybe two at a giant place like this. Yeah, all right. Choriocarcinomas 100% will be hemorrhagic, relatively rare. Other tumors, though, how about primary tumors? Primary tumors, glioblastoma, can present as hemorrhage. Now, more frequently, it looks like a glioblastoma with areas of hemorrhage. What we're talking about in these images, listen, what we're talking about these images is not an obvious solid contrast enhancing mass with focal hemorrhage. We are talking about the appearance of lobar hemorrhage with a fluid level, right? Lobar hemorrhage. So it could be something like conchophilic angiopathy, yada, yada, ruptured vascular malformation, et cetera, okay? All right, are you ready for the histology? Let's see where this one went. Okay, there you go. You can see it's kind of angular, kind of spindly looking nuclei forming sort of pseudo rosettes. In the upper right, there's some kind of whirling, a little bit of whirling. Okay, this is the great imitator, if you will. Here's HMB45, there's melanate. This is metastatic melanoma. Metastatic melanoma, the vast majority are amelanotic in the brain metastases, which means you don't have melanin as a cue. You don't even think about it. When you get a heavily pigmented melanoma, that's just like, oh man, this is too easy. right? It's too easy. The neurosurgeon knows absolutely that it's melanoma for the pigmented examples well before you do, pathologist, because the lesion is black. Even 1% pigmented cells, 1%, it's going to look black when you summate all of that pigment in the tumor. But the vast majority, 2/3, maybe 3/4, are amelanotic, all right? And they can look like anything. The majority are epithelioid. This one clearly is not epithelioid. They can show beautiful whorls. Yes, they can show whorls. They can make rosettes. They can do all of this. So you always can suspect melanoma. All right, and we proved it with the immunohistochemistry. All right, how about this? Let's do a smear warm up. All right, differential diagnosis is what I'm looking for. Here's the whole slide imaging of the smear. Now, again, as we say often in this conference, there's only three patterns that we see on our cytologic preparations. If it's a touch prep, sometimes if it's a drag, sometimes if it's a smear, the tissue falls off, nothing is shedding, so you get nothing. The other two patterns are going to be single cell and clumps. Single cell would be tumors like lymphoma, like melanoma, etc. This pattern is clearly clumps, all right? And clumps can be caused by usually two different mechanisms, cell processes and desmosomes, or both. All right, let's go to higher power. All right, again, I'm giving you a feel for what's going on. And what we're wanting here is differential diagnosis. All right, a little bit higher power. Okay, you're getting a feel for it. Interesting, very interesting. You're developing your differential diagnosis. All right, this is the last, that's the last H&E. I would like to have differential diagnosis. What do you think? What are the types you're thinking? All right, I don't know if everyone can unmute. I think maybe everyone, everyone can unmute. Someone besides Andrea and Zainab. I don't want to put all the pressure on them. Anyone want to see if you can unmute and give me a reasonable diagnosis for this?
PXA?
PXA. All right. That was Barbara Sains. Thank you, Dr. Sains. I believe that was Dr. Sains. Yes, PXA. I love that. Pleomorphic xanthoastrocytoma. It clearly looks glial, doesn't it? It clearly looks glial. And you see these big, ugly cells as well as small cells. Hey, there's a small cell, right? Maybe it's anaplastic PXA, because anaplastic PXAs tend to become more uniform, monomorphic, and small cell when they progress. That's good. All right. Anyone else? Anyone else want to unmute and then remute?
Giant cell glioblastoma?
Yes, thank you. I think that was Dr. Harb. Giant cell glioblastoma. I'm liking that. Again, the fibrillarity and the giant cells, that's fantastic. Anyone else want to take a crack at it before we move on? So here's just a differential diagnosis slide. Okay, that's good. Hey, I love that. You know, I think we're going to continue to do this. This is wonderful. We're getting participation. We're sort of working our way backwards to the 16-headed microscope room where everyone could talk and it's more interactive instead of the chat. All right. And I know everyone in this group, I don't know how many we have attending. It's usually about 30 or 40. Everyone in this group knows how to mute. Everyone knows how to unmute, say your thing, and remute, right? So we have a very sophisticated audience. It's not like a faculty meeting where it's not like a faculty meeting where it seems like, oh, at least 10%, have no clue that they're unmuted. Anyway, I better not go there any further. Okay. Would you like to see the imaging? I'm going to show you the imaging and I'm going to give you another crack at it. Okay, just to confirm. All right, we've got giant cell glioblastoma, we've got PXA. This is the imaging. Would anyone like to unmute and say, yes, this is going to be, I think this supports giant cell glioblastoma, or yes, this is definitely looking like PXA, or no, I think this is metastatic melanoma. Anyone? I'm gonna give you a second. I can't give too long, right? Because I think I have a little over 200 slides, all right, to show, even though I move quick. Anyone? No ideas? Neuroradi. I know we have to have some neuroradiologists that have an opinion. It's okay. I'm gonna open it up to the experts. Yeah. Ideas, thoughts? Okay, let me give you a little bit of help. What I'm showing you here is the compressed medulla. Look at this. I'm sorry, what's that? Say it again.
Could it be giant cell ependymoma?
Yes, that's Dr. Zainab Harb. All right, Zainab Harb. Yes, ma'am. That is exactly correct. This is giant cell ependymoma. How did Dr. Harb know that? Because I'm handing you ependymoma. See, that's why you can't do what they call it, like a one-trick horse. You can't just do one thing. Like all I do is H&E. That's all I have. It's just gonna, it's just going to be a sad existence, a very conscripted existence. If that's all you have, I am handing you ependymoma, but this is a fourth ventricular tumor. It's actually a cervical medullary tumor in this particular example. And if you look at that, look at the axial cut. It's filling the fourth ventricle and it's trying to come out the bilateral foramina of Luschka, right? That is plastic ependymoma from way back in the pre-imaging days. That's what ependymoma loves to do, all right? And then look at the, if you look at the, on the sagittal, look at that beautiful inferior or caudal syrinx. That syrinx, it doesn't mean it's ependymoma, but it's so highly characteristic, right? Yes, very good. So then you have to put the two together. Glial, right? You saw those fibrillary processes, correct? Hey, listen up. Did you hear? I know many people were thinking from the smears, astrocytoma, either PXA, diffuse astroglioblastoma. Did you know that ependymomas have perivascular pseudorosettes? They form pseudorosettes. What are those pseudorosettes made from? They're made from very finely fibrillar cell processes. What happens when, listen, what happens when you smear a perivascular pseudorosette? It's fibrillary. It looks like astrocytoma. How do you know what would be the indication, if I don't give you anything else, indication that maybe it's ependymoma, not astrocytoma? Because the nuclei, it's not in the cell processes, it's in the nuclei. Listen, did you just look at the fibrillarity and go straight to astrocytoma without looking at the nuclei? Why would you not look at the nuclei? The nuclei can be considered another subdomain of this Venn diagram sphere. Within the H&E morphology, we can subset that. That could be another dozen spheres all of its own. It's like breaking down an atom, right? All this internal anatomy. Did you like that? Look at the nuclei. The nuclei of ependymoma are monotonous oval, monotonous round to oval. Most, not all, astrocytomas are going to be more pleomorphic. Okay, you like it? Okay, I consider this the locus classicus. It's not really, but I consider it. Paper 2012, giant cell ependymoma, reported 3 cases. This was actually a collaboration between Methodist Hospital and Steve Coons, all right, who at the time, what was it, the Barrow, and I believe Dr. Coons has since retired, the wonderful Steve Coons, and our former fellow, now neuropathologist at North Shore, Long Island Jewish, Dr. Jim Lee. And look at this, look at panel C there. All right, you can see the perivascular pseudorosettes in B. Look at that. If you've never seen giant cell ependymoma, this is your time to internalize it. There's case 2, case 3. Look at panels B and E. You see those giant cells. Now notice, listen, notice in both of these cases, it's not 100% giant cells like you might see in some PXAs. It's like the whole thing. They're everywhere. Frequently, most commonly in giant cell ependymoma, it's foci, it's islands, all right? Yeah, and that's why, and look at the smear. This is one area of the smear of our case, our patient. And here you see all the nuclei are round to oval, emphasis on oval with the fibrillary processes. This, and some of them are, I didn't show it, it may be lower left-hand corner, adherent to the blood vessels. That is screaming ependymoma. This looks like garden variety, all right, normal ependymoma, all right? Okay, smear preps. This is one of the lessons. Listen, this is one of the lessons. Smear preps of ependymoma look a lot like diffuse astrocytoma, all right? The fibrillarity. The key is in the nuclei. Round to oval, very monotonous. You got that? Try it. Don't trust me. Don't take my word for it. Try it. Pathologist. The next time you're doing the smears, all right, have a look. You have a nice ependymoma. You know it's going to be a ependymoma based on the pre-op imaging. Take a look at the smears. Put it to the test, right? Now, what happens with these when you have islands of giant cells with all this monomorphic ependymoma and you smear it? Well, they run together, and that is what we're seeing here. So what you have is a distributed little island of giant cells that has been smeared and blended into the background. All right, now this is one form, listen, this is one form of what we call biphasic cytology of tumors. The classic biphasic tumor is germinoma, where you have these giant epithelioid germinoma cells, and in a sea of small reactive round lymphocytes. That's an example of a biphasic tumor. This is another example of a biphasic tumor, particularly on the smears. Again, here's the other example. You see the background of ependymomal cells, oval nuclei, yes, the fibrillar processes, perivector pseudorosettes, etc., and then these scattered giant cells. Do you like that? Okay, and then here again, imagine, look at panel A. This is from the paper. Panel A, monotonous regular ependymoma. Look at panel B, an island of the same patient. You smear those, and this is what you end up with, right? When you run them over. Do you like that? Okay, now you may be thinking this was really hard. Well, you know, it wasn't hard for me at the time of diagnosis. It wasn't hard at all. Why? Because I've seen 2.5 billion of them? No, not really. It's because I had this. I had the pre-op imaging. Yeah, I cheated. I looked at the imaging. That's terrible, isn't it? When you have to cheat to give your patient an accurate diagnosis so they get the correct treatment. Wouldn't it be honorable to not cheat? Just give the diagnosis only based on the H&E. About 10% of your diagnoses will be wrong. Patients will not be treated right, won't live as well, won't be cured. But is that more intellectual? Oh, come on. Why would you not look at the pre-op imaging? Why would you not use the 8-Venn diagram sphere model? Look at all of these and put it together to protect your patient. That is the business that we need to be in. Hey, do you like that? Okay, we're still warming up here. I'm going to introduce a new conference feature. This is exciting. I'm going to call it Outside Radiology Reports versus Images. Now, we're talking about outside imaging. Now, I'm not sure how it works at all of the hospitals, which everyone in the audience is practicing, but I can tell you at MD Anderson Cancer Center, there are way too many outside imaging studies coming in across every specialty for our diagnostic radiologists to read. It'd be overwhelming. We would have to order of magnitude more radiologists to do this. There's a mechanism by which primary care physicians, the neurosurgeons, neuro-oncologists, radiation oncologists, me, can request a professional neuroradiologist to read an outside scan. There is a mechanism for that, and they will do it. They love to do that. And that's when you really, really need help. Other than that, you're going to be on your own. You're going to be looking at the scans yourself. Now, you might be saying, no, I don't have to look at the outside scans. I can find the outside imaging report somewhere buried in a 250-page PDF yeah, in the clinical history, right? Okay, so here's a hypothesis. Try this on for size. There is no need for me to examine, I'm talking to the pathologists here, there is no need to examine referring institution MR imaging studies if I have their radiology report to read, all right? That's all I have to do. Well, let's take a little test case. Again, remember in this conference, everything I draw from this conference happened from the interval when I was before I presented the last conference. So everything here is only 3 weeks old, right? And sometimes we have throwbacks going way back, but it's a current page. Everybody got, okay, 22-year-old female. Here's the referring institution radiology report. Everything is always anonymized in this conference, all right? Current impression, I'll read it. Multifocal masses in areas of mass-like flare signal abnormality throughout the left cerebral hemisphere with extension across the white matter tracts and additional flare signal abnormality along the right lateral ventricle. Findings are concerning for multifocal high-grade glial tumor, such as glioblastoma. Okay, there it is. So you might say, look, this is a radiologist, board certified radiologist, probably making a lot more money than I do. I'm talking to this as poor academic pathologist, not so much in private practice, not so much dramatic. Okay, I'll stop there. They're telling us glioblastoma. It's going to be a glioblastoma. Was it multifocal, large infiltrated masses, left cerebral hemisphere, T2 hyperintensity, T1 hypointensity with minimal, if any, enhancement. So no enhancement. Okay. Would you like to see the actual images, or are you thinking, what's the point? I've read the radiology report. The tumor is probably going to be a glioblastoma. Hey, did that last sentence say it wasn't in hand? Yeah, never mind. It's probably going to be a glioblastoma. If there was anything else of importance, the radiologist would have told me, would have put it in the report. Now, listen, I'm going to trust my neuroradiologist here at MD Anderson Cancer Center. I'm not doing it in the outside, and neither should you. Neither should anyone. All right? All right, here we go. All right. Are we all in agreement that there was no need to look at this? It's probably glioblastoma, of which 85, 90% initial presentation or IDH wild type. This is going to be, patient needs to be treated with Stoop protocol. All right, that's chemoradiation with either PCV or temozolomide. Everybody good with that? Good glioblastoma. Look at that far right panel. T1 with contrast, it's non-enhancing. Oh, that was that little footnote. The little footnote said minimal, if any. All right, well, I have the images, all of them. I scanned them up and down. It's not minimal, it's none, it's zero, it's not enhancing. Now, you can have, listen, I'm saying you can have, I didn't mean to say, I'm using personal pronouns. I critique our oncologic surgical pathology fellows in their unknown case concerts for using personal pronouns. They'll say something like, your GFAP shows, it's not yours, it's not mine. I just said, the bottom line is, it is possible certainly to have molecular non-enhancing glioblastomas. That would be a non-enhancing IDH wild-type diffuse astrocytoma in an adult. It's going to behave like glioblastoma. Fine. Yes, absolutely. But traditionally, classically, no, that's not going to be top on your list. But that's not the big thing. The big thing here is the T2 flare mismatch sign. Okay, whoa, hang on. Did you see when I showed you the report that it was 2020? This is this year. This is not going back, to 1982. This is 2020, and the radiologist in the report did not say T2 flare mismatch sign is present, which strongly suggests the possibility of IDH mutant diffuse astrocytoma. Did you see that in the report? And I gave you everything. There's nothing missing. Is this a cautionary tale? Have I made the point? And I know I won't name names. I have had people in the past tell me I am not a neuroradiologist. All right. And let me ask you this. Okay. Let's say as a neuropathologist, let's say I told you there's a mechanism whereby I can request a formal reading by one of our expert neuroradiologists. What do you think they would do if I start requesting a formal read on every single outside case I see? And you know how many outsides we see? We see between 1.5 to twice as many as in-house surgicals. No, that's not going to work. There's not enough time in the day. That's why I have done that before. Absolutely. And I've done it even more frequently as an informal curbside when I need help from a true expert, board certified, trained, experientially trained, fellowship trained oncologic surgical neuroradiologist, but not for bread and butter like this. Some of our neurosurgeons who scrub out to look at their frozen sections can recognize mitotic figures better than fellows, better than residents. Yeah, absolutely. We have to be able to speak each other's language. Okay, I think it's a great lesson. Okay, here we go. This is IDH mutant diffuse astrocytoma, done and done. Here's the report. Let's have a look. I've redacted it, anonymized. Diffuse astrocytoma, IDH mutant, WHO grade 2, and it shows the classic triad of IDH, ATRX, TP53, all right, alterations of IDH mutant diffuse astrocytic disease. So that's another route to get there. All right, you like it? Anything catch your eye here about the report? Take a second. Anything? Anybody want to unmute? Anything catch your eye? Looks like there's two sets of data and they're clearly separated. They're clearly separated into two sets, as you can see. Anything catch your eye? There's something interesting here. Something interesting that should catch your eye. Anyone? Do you agree with the way it's formatted? I always put the critical molecular signature in the diagnosis, and this is the critical molecular signature, and it supports the diagnosis of IDH mutant. There's something interesting here. What is it? Okay, good job. What's odd about ATRX versus IDH and TP53 in terms of the way they're listed in this report? What is unusual? All right, what I see in the first group, I see C in parenthesis, IDH 132, NGS, and ATRX IHC, and then TP53 NGS. And then the bottom set, it's IDH IHC, ATRX NGS, P53 IHC. Why? Why? All right, there's two obvious ways to arrange 6 pieces of data. Okay, we have 3 genes, that's the IDH, ATRX, and P53. And we have molecular data, genomic data, which is the NGS, and we have protein data, immunohistochemistry. All right, there are 2 obvious ways to arrange the 6 pieces of data. One is you could group the cognate gene and protein together. So you could have IDH1, IDH2, NGS result, and right below it, IDH1 protein status result, right? And then the next 2 lines would be ATRX NGS and ATRX IHC, and then TP53, and then P53, right? Or another way to do it, why don't we group all of the IHC together, and then group all of the NGS together. And you could put IHC first, because I guess that chronologically, that's the way you would acquire it. Or you could put NGS first. If you think that's the better, more superior data, you could put that little group first, correct? Yeah. Well, the way the data are grouped here in this report, and I'll be honest with you, this is my report, it's neither of those. Why? Why? Okay. I'll offer a hypothesis. Hypothesis one, it's just a mistake. It's just sloppy. One got out of order because I was rushed, you know, because everyone knows the status now at Indiana Cancer Center. We've got one full-time clinical neuropathologist and one essentially full-time outstanding research neuropathologist. That's Dr. Hughes. It's me and Dr. Hughes. Dr. Hughes 20%. I'm 80%. Wow, I'm covering every day in January except for one every workday. And I am, you know what? I am looking forward to it because I am going to see so much great material in January. I can't wait. And you will be the beneficiaries in the case conferences. I promise you. All right, I'm rushed. So I made a mistake. I was sloppy. I was rushed. There was what? What is that? Oh, sick. Hey, it's time to take a little break here. That was getting intense. Let's have an IDMCC vocabulary moment. Sick. What is that? The Latin verb sic, thus, just as. The full phrase, it's an abbreviation for sic, erat, scriptum. Thus was it written. Inserted after a quoted word or passage indicate the quoted matter has been transcribed exactly as found in the text. Complete with any erroneous, archaic, otherwise non-standard spellings. It's not an error transcription. Skip all the way to the bottom paragraph. Sic may also be inserted derisively to call attention to the original writer's spelling mistakes or erroneous logic, or to show general disapproval or dislike of the material. Ooh, you mean I can use sic as a weapon? Okay, I just took to prove the point. That was a vocabulary moment. I fixed it. Mistake, sloppy rush, no proofreading. What do you think about that? Yeah, it happens. Mistakes show up in my reports like in everyone else, despite the fact that I proofread. We're human, but I try to minimize it. I consciously minimize it. Okay, let's offer hypothesis number two. It was done deliberately for a reason. You mean ATRX protein was put in the top group with the NGS of the other two deliberately for a reason? All right, here's the point. Point number one is, I know we're moving fast through this, but I did give you a minute to look at it, to consider it, right? So point number one is, did you notice it? Did the brain register that there are two gene data in the top group and one protein, and then two protein and one gene data in the second group? Did it even register? That's called eye for detail. Eye for detail. It can help you in diagnostic medicine, radiology, pathology. All right, second, this is even more important, if you did notice it, did you instantly think, oh, I don't like that, that's a mistake, I would have done it the other way, I would not have made that mistake, he must have been rushed, and then you moved on? Okay, here's the thing, simply entertaining the possibility, just considering, just thinking, I wonder if this, what appears to be a blatant error, something easy, something simple, something stupid, I wonder if it may actually have been done on purpose for a reason, and then consider, is there any way in which that might have been done for a reason? If you even considered it, it doesn't matter if you were able to figure it out or not, or if you came to the conclusion after thinking about it that it was a mistake or an error, it doesn't matter, and you concluded it was a mistake, that's fine, but just thinking about it is what separates excellence from mediocrity. What does mediocrity do? Mediocrity sees something like this and says, oh, there's an error, moving on, and doesn't think about it, doesn't. Mediocrity sees an unusual and interesting, sort of odd finding in a radiograph, in a tissue section, but it's not part of the main diagnosis. I've got the main diagnosis, satisfaction of search, yay, I've got it, moving on, just forget about it. Excellence is going to try to figure out what that little minutia is, because that minutia might actually become important, if not in the present case, then a case coming in the future. And taking the time to do that, to figure it out, get help from your colleagues, get help from the attendings, get help from your friends across the country, across the world, send the image. That is what separates excellence from mediocrity. The ability to entertain an idea, to consider it without swallowing it whole, critically consider it. That's excellence. Okay, this was done deliberately for a reason. All right. The first group of 3 assays comprise the gold standard. That's why I put them first. These are the gold standard. It's NGS or PCR for IDH and TP53, and it's protein. It's IHC for ATRX. Yes, IHC is the gold standard, not PCR, not NGS, for loss of ATRX protein function. And the important thing in the pathophysiology, listen, the important thing in the pathophysiology of IDH mutant diffuse disease is loss of ATRX protein function. It's not a mutation or duplication or a loss or fusion. It's the loss of the protein function, not alteration of the gene. Okay, now wait a minute. Loss of ATRX protein function occurs secondary to a wide variety of mechanisms in different tumors, of which ATRX mutation is only one. Hang on, it's like, you mean to tell me that loss of ATRX protein by immunohistochemistry can occur in the context of a normal wild type ATRX gene on oncomine, on NGS? Yeah. Yes, we see it all the time. And it's not like, oh, here's a discrepancy. There is no discrepancy between failure to identify or there not being present any alteration in the wild type gene and loss of the protein, stone cold, unequivocal loss of the protein with internal endothelial, normal glial positive control. Yes, absolutely it occurs. How? I mean, are there any, well, of course. Promoter modification, post-translational alteration, other mechanisms, multiple mechanisms. Yeah, absolutely. Now, here's the thing. This is simply a knowledge-based issue. This little factoid, this is what I like to call factoids. And this conference, the IDMCC, is never about memorizing factoids, ever. You will get factoids, you will get knowledge, your knowledge base will grow, I promise you. But that's not the main point. The main point are the principles which are applicable to all specialties, to all areas. It's the principle. So that's knowledge base. Here was the principle, what I wanted to call attention to. Just considering the possibility of this hypothesis 2 is what separates excellence from mediocrity. When you notice something unusual, you take the time to think about it, to consider it, to analyze it critically. And listen to me. You take the time to think, could I be wrong? Could I be wrong in my snap judgment and all of my infinite wisdom? I'm a board certified, neuroradiologist. I completed a neuroradiology fellowship. I have been in practice in oncologic neuroradiology and oncologic neuropathology for 30 years. Could I possibly be wrong? And the answer is yes. You absolutely could be wrong. I'm talking to myself as much as to you. What separates excellence from mediocrity is being aware of that fact and being conscientious enough, humble enough to consider the possibility that you might, upon occasion, be consummately wrong and defending against it by testing your snap judgment, including little errors or critical things when you think you found a mistake. Take time to think about it. You like that? Okay, there we go. Separating excellent from average. Okay, does everyone feel warmed up enough to actually try a patient case? Okay, we have 7 minutes left in the conference. All right, I can cover these. We have 2 patients. I can cover them easily within 45 minutes. Okay. Okay, we're going to run over for sure because I'm going to take my time with both these cases. Anyone has to leave. I totally understand clinical obligations, or you have to catch a bus, or yada yada. It's no problem. If you attended, you want the recording. If I was successful in recording this one, it's always a question. I will send you a copy of the recording. Okay, here we go. Patient number 1, 40-year-old female, MR imaging. Let's look at the imaging. Give you a chance to absorb it. I want to give a chance for all the advanced people have a crack at it unaided. I'm gonna go ahead. Let's label sequences. Upper left across T1 with contrast, T2 flare, gradient echo, diffusion weighted imaging. Okay. What we're going to do is we're going to run through everything. I'm not going to comment. All right. We're going to look at the histology now. We're going to go through all the images, and I want you to formulate your differential diagnosis. See if you come up with a differential. Remember, the most statistically, most common, most likely, statistically probabilistic, most common thing based on the data that you have needs to rise to the top. All right, I'm not going to comment on it. Then we're going to go back. We'll look at every single one of these, and I'll tell you the reasoning I went through and just things that you may or may not have observed. All right, there's whole slide imaging. Give you a second to absorb this, and I'm going to show you how I approached it, what I saw. Doesn't mean, you know, I'm perfect or saw more than others. All right, another area of the tumor. Here's an area. We're pattern recognizers, whether you're radiologists, pathologists, you know, we all work the same, our brains work the same, picking stuff up. Another area. Probably formulating a hypothesis right now. What you think is going on. Not trying to sway your judgment. Okay, everybody there? You got it? What diagnosis does the H&E histology, the constellation of H&E features, strongly suggest that you need to consider in your differential diagnosis? Someone want to unmute? Zainab.
Glioblastoma with FGFR TAC3 fusion.
Beautiful. Congratulations, Dr. Harb. Surgical pathology resident, soon to be neuropathology fellow, soon to be oncologic neuropathologist. Yes, bingo, right on the money. Let's go through it. All right, so what we see, it's a contrast enhancing mass. It's T1 plus contrast. You can see it has enhancing components. It's also multicystic. You can see on the T2. It does not completely suppress with the fluid attenuation version recovery, probably due to protein content of the cyst. The gradient echo, you can see a few densities. They look like linear densities. That's going to be calcification. It would be an unusual shape for blood. Diffusion weighted imaging, not a whole lot going on internally, maybe some at the edges. This is a CUSA, surgical specimen, cavitational ultrasonic surgical aspiration, like we saw earlier. All right, look at this. This was the first slide. What does an oncologic neuropathologist see in this tableau? What I see to my eye, I saw three things, three separate areas, three separate things. In the far right, most obvious, vascular proliferation. That's the contrast enhancement. Instantly, my brain, my mind is thinking, oh, that correlates with the contrast enhancement. I have just explained the contrast enhancement. All right, microcalcification. So that's interesting, not pathognomonic for anything, but very characteristic of different things, including what we're talking about right now, this entity. Got a characteristic of oligodendroglioma as well. All right, there's the microcalcifications, and clearly a major oligo-like, we'll call it oligo-like, could be oligodendroglioma component, very monotonous round cells. Necrosis, okay, that goes along with this very heterogeneous, very heterogeneous neoplasm, obviously, in addition to the cystic component. This is tumor necrosis. So now we're thinking about bumping it up. There's necrosis. Oligo-like cells, delicate endocrinoid. We in neuropathology traditionally we have called that chicken wire vasculature. Endocrinoid is a term used by the endocrine pathologist, general surgical pathologist. A little more common. It's the same thing. Again, looks like oligodendroglioma with the perinuclear halos, microcalcifications, more of the same microcalcifications. This is very, very oligo-like. The vascular proliferation would mean anaplastic oligo. So now I'm sort of going back to the imaging, and I'm thinking with that imaging, oligos can be cystic for sure. Most of the ones I've seen have been a single cyst, a single big cyst like cystic glioblastoma, but that's okay. It's a spectrum. Okay, it's sort of, now there's no halos. That's fine for oligo. Oligo does not have to have the FFPE, formalin fixed paraffin embedded, artifact of the cytoplasmic hydropic swelling, which is the perinuclear halo. It's very common in normal oligos. It's common oligodendroglioma. You do not have to see it. It just depends on the formation of the artifact. In some cases, a beautiful oligo, there's no halos. That's fine. There's something that's troubling here, and it's not the absence of halos. What is troubling here? What's troubling here are the nuclei. Look at that nucleus. In what way is that round irregular? Do you think that is that electrocautery? Is that cautery artifact? No. Look at the vessels. The vessels are fine. That's not cautery elongation. And the more you look, I'm getting the impression that the majority of these cells are oval, sort of like a ependymoma, not monotonously round like oligo should be. Oh, game over. What oligo has nuclei that look like this? No, and this is not distortion. Again, you can tell from the blood vessels, endothelial cells, and all of that. There's no distortion here from cautery, all right? And those are perivascular pseudorosettes. This is rosette formation. Oh, well, again, looking like this, perivascular pseudorosette is not a common finding in traditional oligodendroglioma. And look what's going on here. Look at how elongated in this area the cells are becoming, that spindling. So we have, and look at that upper right panel, that's spindle cell. And again, no distortion. You can look at the blood vessels, other cells, nuclei are not distorted. That's the innate biology. So let's look at the constellation. Oligo-like cells, round perinuclear halos, endocrinoid reticular vasculature, microcalcifications. So far, we're great for oligodendroglioma. Perivascular pseudorosette, no, not so much. Spindle cell areas, no. Oligos in general don't do that. Oh, after surgical operations, you know, you'll have gliosis doing all that. I'm not saying it doesn't. Everything happens. You might find on occasion, but no, not like this and not multiple areas. Okay. What diagnosis does this constellation histologic feature strongly suggest you consider adding to your differential diagnosis list? This constellation, FGFR fusion glioma. Most commonly, it will be FGFR3 TAC3, as Dr. Harb said. Occasionally, there will be other fusion partners, and it can also be other FGR subtypes, particularly FGR1 can become involved, but it's a smaller subset. All right, you want to see the diagnosis? Let's run through it. All right, here we go. Glioblastoma, IDH wild type, Dotro grade 4. H&E stain section showed diffuse astro, elevated mitotic activity, vascular proliferation, necrosis, histologic features, diagnosis of glioblastoma. Areas of tumor some areas show small cell subtype morphology. Ooh, that's intriguing. Now, everyone can tell, by the way, if you look at that diagnosis, how it's formatted, this is not my report. All right, that's because I don't format my reports like that, right? Okay, I'm just saying. All right, so areas of tumor show small cell. That's the oligo-like morphology, okay? As well as the more oval and elongated. All right, here's the molecular signature. Whoa, oh man, we got a bunch of molecular data here. Okay, let's look for FGFR. Where is it? Where's the FGF? Oh, wait a minute. PCR, IHC, FISH, PCR. PCR is not NGS, right? Those are single or individual reactions. Next generation sequencing, that's the modern day massively parallel PCR, if you will. It's, you know, everything at once. This sort of, okay. No NGS. There's no next generation sequencing. That's why we're not seeing, well, look, honestly, is it really needed? It's glioblastoma. Why not call it glioblastoma, list what's there, and go home? Done your job. Stuke protocol. It is a glioblastoma. You've done your job. Do we really need it? Yes. The histology says you need it. And guess who looks at the histology? Is it the neuro-oncologist? Is it the neuroradiologist? Is it the neurosurgeon? Is it the neuroradiation oncologist? No. Pathologist. It's up to you. You either do it or it doesn't happen in cases like this, coming in from the outside. Now we're moving into the era where hopefully every patient, inside, outside, all of them will be getting even more extensive NGS profiling, probably other platforms than we have in the past. But look, we're still in the transition zone, and there's still cases where you're gonna, it's the onus is on you, pathologist, to pull this out. All right. And I have done it in this exact situation. I think this was the 4th or 5th time. All right. The histology specifically, I say specifically, what testing does the histology say needs to be performed? And is it fusion testing? Fusion testing needs to be performed. Oh, guess what? It was on the outside. They had outsourced it. They had outsourced. I had earmarked this case. This case was not assigned to me. It came through, patient being seen at MD Anderson. I looked at the histology, earmarked it. I had a strong suspicion that's what it's going to be. I earmarked it to follow up, and lo and behold, check it out. This addendum is being used to report the results of gene rearrangement and announced RA sequencing. Transcript identified FGFR3 FKBP15, an alternative partner, all right, not the TAC3, FKBP15 chromosomal rearrangement. There it is. This is an FGFR fusion glioma. further in the report here. This is from one of the reference laboratories. Potentially actionable. Yes. All right. Chromosomal rearrangement. It's not because of the partner, the FKBP15. It's the FGFR, which is doing that. And guess what? Yeah, here it is. Therapies, pan FGFR inhibitor, and there are more specific inhibitors in the works. Erdafitinib is the one being tested. And guess what? Clinical trial right up the road from me, right up the road, here in Dallas, UT Southwestern. Yeah, clinical trial, phase 2, put them in the trial right there. That would not have happened in these cases if the pathologist had not been on their toes and identified, you know what? This could be an FGFR fusion glioma based on, guess what? This ancient technique using a microscope, H&E histology. Why would you not want to have that? Again, we're talking about knowledge base, but that's pretty cool. And it also emphasizes a critical role that the pathologist can play. All right, do you like that? Okay, and it's a principle. It works exactly the same way in diagnostic radiology, neuroradiology. The same thing, the knowledge base, the principles, right? Okay, and actually we are about to illustrate that. Listen up, we're going to illustrate that right now with patient 2. Now this is the last case here. Let's go through it. Patient 2, 20-year-old male. All right, guess what? I just gave you 2 Venn diagram spheres. You know the patient is in this young adult 20. That's actually at the bridge between childhood, adolescent, young adults in that group. If you want to subset that way, young adult. Okay, and this is actually I'm going to make this a professorial challenge. You know why? Because I know that we have several highly advanced oncologic neuroradiologists at the top of their field that periodically attend this conference, and I have to have something for them to just a little test. All right, so I'm going to make this professorial, all right, level. And what I want is a diagnosis. Now, yes, there's always a differential. Yes, agreed. And we saw that with the meningioma mimicking vesicular Schwann. Yes, here's what I want though. What I want to know is what is at the top, statistically most likely based on the data that you have, scientific. This is all evidence-based. What is at the top of your differential diagnosis based on the data you have for this patient? You got it? I just want one diagnosis, all right? And I will explain it. I'll go through it, okay? I'm not saying it's difficult. I'm not saying that. I'm just saying we're going to go through it. All right, let's look at, this is head MRI sagittal section. Okay, just for those who may not be familiar, here is the lesion. Again, it looks like cervical medullary. The rest of the action I'm showing here in the spine film, and this is cervical and upper thoracic. Let me give just a minute here for the for Octavio and any of our oncologic neuroradiologists attending to digest what's going on without any aid, formulate all the pieces. There's a lot that we're learning from these images, a lot, not just one thing, more than one thing. I think many of you could probably appreciate this as T1 with contrast, as contrast enhancing. There's a lot more going on here than just contrast enhancement. All right, now for those who are not as familiar with the technique, which is fine, this is complex. Spine is almost always, can be more complex than brain. Skull base is more complex than brain. Spine can be very difficult. I'm highlighting the tumor, all right? Yeah, I'm gonna tell you it's a tumor in this case. So I'm giving you a big advantage. These are sequential, listen, sequential, which means in order, slice by slice by slice. I may have skipped a few in between, slice by slice by slice, parasagittal, all right, moving all the way through, and I'm highlighting the tumor as you see it, okay? And then let's just simplify it here with these native T2s, again, highlighted, just writ large, if you will. This is telling you something, all right? Besides, I think everyone here is sophisticated to know that it looks like there's some cysts. T2 visualizes water, all right? And then this is a T1 without contrast, far left, then a T2 in the middle, and T2 with fat suppression far right. Okay, and then just one more, and this is just large series of the T1 with contrast, giving you a feel for the contrast enhancement of the tumor. You got it? Diagnosis. Okay, I'm going to open the floor, and I would like for, let's let the trainees take a crack at it first. There's always a differential. So whatever you say, the odds are whatever you say, unless it's maybe, you know, metastatic hepatoblastoma, that's probably going to be a wrong answer, maybe an F, maybe a 0. Not that it doesn't happen. We had a case of that last week. Dr. Harb, what's your diagnosis?
Maybe a spinal arachnoid cyst.
Oh, spinal right. Oh boy, that's going for it, swinging for the fences. I like that, Dr. Harb. I actually like the fact that you're taking chances, even though I said that this was a tumor, a mass for sure. I like that. Thinking outside the box. That is to your credit. You always have to think outside the box. Okay. What else? Who else?
Pilocytic astrocytoma that's metastasized.
Okay. Yes, very good. Kristen Huntoon, thank you, neurosurgeon. All right, I like that. Pilocytic astrocytoma. I like it. Let's have someone else. This is fantastic. This is the way the conference is supposed to be. Anybody else want to take a shot? Nothing else in your differential? No?
It could be a metastatic glioma or astrocytoma as well.
Okay, who is that? I can't, is that Andrea? Andrea Gilbert? No.
It was Kristen, but
Oh, Kristen, no, I'm sorry, Kristen, what were the entities that you just added?
I just said metastatic astrocytoma and glioma.
Okay, good, fantastic. Okay,
Yeah,
okay.
This is Andrea. I would just say a diffuse glioma.
Okay.
In addition to the pilocytic.
Okay, got it. All right, thank you, Andrew, for speaking up. It takes guts to speak up. You know, seriously does, but you should always do it. And you know, it's like you're with friends. My goodness, how long has this group been together? We're like 30 some odd typically, you know, every couple of weeks. We're friends. This is a unique quorum. All right. I'm going to call it the Fuller Salon, going back to the, you know, like the 1800s when they met in a living room, discussed philosophical ideas. All right. Are you ready? Are you ready? Oh, you're going to love this. Everyone is going to love it. No one has gotten the right answer. And I'm going to tell, and I will show you why in this case, that it was a fairly classic, absolutely classic example. There is an entity that should have been #1 on your list. You know what one of the first clues was?
Neurofibromatosis.
What's that, Dr. Harb? Okay.
I thought of the neurofibromatosis.
Oh yeah, neurofibromatosis. I like that. Okay, that's good. All right, listen, here's the thing. I like that, yes, as a disease. The key was scoliosis. See, that's why I was showing, did you see how the tumor came in and out? The scoliosis was one, not pathognomonic, it was one of the keys. What are the most, let me ask you a question. What are the most common tumors, intrinsic tumors of the spinal cord? That's going to be diffuse astrocytoma, which could be lower grade, or glioblastoma, or H3K27M, right? Diffuse midline glioma, all of those flavors of diffuse astrocytoma. Ependymoma, those are going to be the big two. And then you can have, you know, and so on and so forth. There's hemangioblastomas. Okay, here's the thing. Which of those are associated with scoliosis? Now, see, that's why I was making a big deal about saying there's more information here than just the fact that there's a tumor and it's contrast enhancing. I was trying to say, look at the scoliosis. That is a huge clue. Okay, let's go through it. This is fun. Let's get it going here. Okay, we need to get the weekend started. This is the best way to start your weekend. No? Yes. All right, I think it was 4 or 5 H&E slides with this much tissue, tons of tumor. What does that tell you? What that tells you is it's not a diffuse astrocytoma, it's not glioblastoma. No neurosurgeon is going to keep resecting a glioblastoma in the spinal cord, right, with this much tissue. I've already given you a huge clue. Now you should be thinking, I've already told you no one's gotten the correct answer. So you should be thinking, oh, if not those, which one then? Okay. Wow, Rosenthal fibers everywhere. Okay, so it's a pilocytic astrocytoma. Except it can't be. You know why? Because someone already said pilocytic astrocytoma. And I said no one's gotten the correct answer. So it's all these Rosenthal fibers, and these are neoplastic. Yeah, that's pilocytic, if you will. It is, but it's not pilocytic. Could they be reactive? Well, I'm looking at the new, look at the Dr. Harb. You want to say something? Dr. Harb, were you about to volunteer something? Okay.
It's Alexander disease.
Okay, thank you, Dr. Harb. I love that. Okay, again, you know what I love about what Dr. Harb is doing here? She is giving us all the diagnoses that no one would be thinking about. So from the diffuse arachnoid cyst and all this stuff to Alexander's disease, which is wall-to-wall Rosenthal fibers in the cortex and the white matter, cerebellum, spinal cord, everywhere. I love that, Dr. Harb. I love that diagnosis. But in this particular case,
But you said it was neoplastic, though.
yes, yes, Dr. Gilbert. Yes, I did. The diagnosis is wrong. No piling on. No piling on, Dr. Gilbert. Okay. Okay. Thank you, Dr. Gilbert.
All right.
Actually, your laughter is very pleasant. So, okay, here, let's go. Let's move. All right. So Rosenthal fibers. Look at the blood vessels. That's you can go ahead and remute. There. Thank you, Dr. Gilbert. Look at the blood vessels. Look at the blood vessels here to the far left, far right, sclerotic. What does that mean? It means long time, long time. That goes along with the expanded canal. Did you see how large this was? How large that canal was? It's remodeled. That should have struck you as, man, this is a massive thing in this canal. It's remodeled the bone. The vessels and the Rosenthal all goes along with chronicity. All right, here's another component. Look at that. Oh, okay.
Was this patient irradiated? No,
ma'am. No radiation. Initial presentation. In fact, the entity, no radiation. Okay, good. Thank you. Continuing to think. I'm liking that. Look at this component. Halos. Okay. Well, how about? Can you see oligo-like cells in pilocytic? Yes, absolutely. You can. But I've already told you it's not pilocytic. Furthermore, look, the halos in some cases are surrounding 2 or 3 cells. That's not what the oligo-like component looks like in a classic pilocytic. All right, now here's an area, I like this slide. Look on the right, you see all the Rosenthal fibers, and on the left are these odd cells with the halos. Here you see the halos on the right, and then we're transitioning to an area where there's no halos. Which is fine, but what, so maybe this is astrocyte. They look a little pleomorphic, don't they? Some a little large, some a little small, very little cytoplasm. Maybe it's astrocytoma, diffuse astrocytoma. I think we've already kind of dealt with that. Okay, spinal cord. So the anterior horns, all right, these have the lower motor neurons, anterior horns. So what the neurosurgeon has done here is resected all of the anterior horn of the cervical and upper thoracic spinal cord. Now, what happens when you resect all of the anterior horn, lower motor neurons of the cervical cord and the upper thoracic? I'm not liking my hypothesis at all. I'm not liking that. What's the diagnosis?
The ganglioglioma.
Ganglioma.
Of course it's a ganglioglioma. Of course, you should have known that from the imaging. Idiot. I'm just kidding. You know what? I tell myself that all the time. All right. The fact of the matter is I did not expect you to know that, right? But this is the best I can do to stimulate your limbic system so that you will never, ever forget this. It doesn't mean you're going to be 100% accurate. And we're going to go through it. Now, those are binucleate. Everyone see all these, they're everywhere. This is ganglioglioma. In the greatest percentage of gangliogliomas, do you know what the glioma component looks like? Pilocytic astrocytoma. Pilocytic astrocytoma. Gangliogliomas usually look like pilocytic astrocytoma, and on frozen especially, until you get the permanence and you have 3 or 4 blocks because the treatment's gross total resection. And all of a sudden, here are 1 or 2 little clusters of binucleate ganglion cells as a ganglioglioma, right? Yeah, so you always have to be aware. That's a caveat. Be cautious about circumscribed enhancing tumors. Jumping to pilocytic without considering ganglioglioma, always do that. I just can't show enough of these. Isn't that gorgeous? Look at those ganglion cells. All right. By the way, I diagnosed this on the smear at frozen. It was pretty obvious what it was. All right. And look at this. This is, I call this the best single image of the whole case histology. On the right, you see the Rosenthal fibers. You see the sweeping sort of pilocytic morphology. In the middle, lower, you have this hyalinized blood vessel, says chronicity. There's some lymphocytes in other areas that are more impressive, perivascular lymphocytic, reactive lymphocytic cuffing. And then in sort of just left of midline, you see these beautiful giant ganglion cells with Nissl substance, multinucleated. And then to the far left, what do we call those cells? What do we call those? These are the ones with the halos, kind of oligo-like. What do we call those cells, Dr. Gilbert?
Gitter cells. Gitter cells.
Well, no, macrophages, no Gitter cells, no. That's a good guess. I like it. These are ganglioid cells. They stand for neuronal markers. They're called ganglioid. I believe it was the late, wonderful Dr. Bernd Scheitauer who coined that term ganglioid. What is a ganglioid cell? And specifically, he described it in the context of ganglioglioma. A ganglioid cell is a smaller ganglion cell, which typically does not have much, if any, cytoplasm, no Nissl substance, but still is clearly neuronal, stains with neuronal markers, and is not a neuroblast, no mitotically active neuroblast. That would be ganglioneuroblastoma. It's a completely different animal, right? These are ganglioids. So that's new knowledge if you hadn't encountered these smaller ganglion cells without all the cytoplasm, without all the Nissl. You got it? That's magnificent. Here's the diagnosis. Ganglioglioma WHO grade 1. Okay. And here is the list. Now look, but fine. That's fine. And if you like, the point of this case was not to get people to make a wrong diagnosis. We never do that. There's no point to that. The point is, and for this case, is to increase knowledge base. And here it comes. Here's the imaging. Now, what I told you, what I said is that you should have had ganglioma in your differential. Now, the first reason you should have had ganglioglioma in your differential is because it is it is uncommon, but not really. It's not that uncommon. It's not like you're going to report, you get a ganglioglioma in the spinal cord. You can't report that. You can report it in a trash journal, but there's too many cases. Oh, here's how you would report that. Ganglioglioma of the spinal cord, and your intro to sell it to the editor, in your letter to the editor, we report there are fewer than 2,000 cases of ganglion. Yeah, you'll see that. Actually, what you'll see is there are fewer than 150 cases of. I've seen it. That's pathetic. All right, here's the bottom line. It's that common. It's that common. It needs to be in your differential for circumscribed masses. So does hemangioblastoma. But ganglioglioma, if it was not in your differential, it is now, isn't it? For everyone in this audience, this may be, along with the principle that we discussed earlier, the excellence versus average, that concept, this is probably the biggest, I don't want to call it factoid, but piece, let's call it fund of knowledge. All right, so, but we have to go through it. Specifically for this case, listen, specifically for this case, it should have been higher up on your differential. All right, the diagnosis of, so this is the last paragraph of my comment, not the whole comment. The diagnosis of spinal cord ganglioma is congruent with preoperative MR imaging features, which show an expansile, cystic, and solid intramedullary spinal cord mass extending from cranial cervical junction to upper thoracic spine, associated with bony remodeling and scoliosis. All of these features, let's go through, let's enumerate them. Long segment tumor extent, the segments, that's the number of vertebral body lengths involved. Long segment tumor extent combined with intratumoral and reactive read syrinx, okay, intratumoral and syrinx formation. All right, see at the very top, that's a syrinx at the very top of this lesion. And then within the lesion, particularly look at the T2 with fat sat on the right, look at all of those cysts, all right, within the lesion, all right? Bony remodeling of the spinal canal and scoliosis are more common in spinal cord ganglioglioma than in spinal cord ependymoma or spinal cord astrocytoma. And those are the other two single most common types of tumor. Remember, common things are common, and unusual variants of common things are typically more common than zebras. So the big two in your differential of an intramedullary spinal cord mass always have to be ependymoma and diffuse astrocytoma, including glioblastoma, right? All right, but those features we just said are screaming, listen, they are screaming ganglioglioma. And that was the problem. The problem was lack of fund of knowledge, or just an absence in this one lacune. Now it takes a lifetime and it's ongoing to build your fund of knowledge. Now the fund of knowledge right now, the big forefront that's advancing definitely is molecular signature. No question about it. Getting all that stuff down, but you have to put it in context, of course. But you know, there are still, for all of us, listen, for all of us, there are these lacunes, a little gap in your fund of knowledge. You can't pick it up, you know, in a residency. You can't pick this up in a 2-year fellowship. You know, it's going to take years of practice, but this is how you build it, case by case, and having an experience with a real live patient. All right. Now that's a powerful statement to make. I just said they're more common based on what? My experience? Absolutely not. Let's go back to 1998. That's why I'm calling this a lacoon. This has been known for some time. All right, look at the greats here. Doug Miller, all right, oncologic neuropathologist. Lucy Rourke, legendary pediatric neuropathologist. Fred Epstein, magnificent pediatric spine neurosurgeon par excellence. Wow, what a stellar cast. Look at the first patient. This was the first patient. Does that look like our case or what? See the syrinx at the top, there's an asterisk there, and he would call that, the extratumoral cyst. The arrows are showing tumoral cyst. That is the first patient. Let's look at our patient. Oh, come on. You don't see any similarity here? Oh, cut from the same mold. Okay, that was a 5-year-old. Look at this is another patient, and that 21-year-old man. What was our patient? 20-year-old man. All right. And again, the imaging not quite as pretty. This was a hollow cord. You see that in legend, 21-year-old man with hollow cord, the entire cord. Oh yeah. And I'm going to jump ahead just a bit. A hollow cord tumor, again, number 1 on your list, entire cord should be ganglioglioma. If you didn't know that before, you do now. All right, let's look at the table from the paper. Comparison, size, yada, yada, yada. We're going to look at ganglioglioma versus astrocytoma and ependymoma. All right, and astrocyte, ependymoma being the most common. Let's look at tumor size. Number of vertebral segments. Look at ganglioglioma, average 8. Ours was definitely over 8. It was all of cervical plus the upper thoracic, and we are right there. Look at astrocytoma and ependymoma, the mean 4. All right, sure, there are exceptions. You can see up to 13 astrocytoma, up to 8, but we're talking, remember, we're never talking about putting all of our eggs in one basket, making a diagnosis off one little sphere of that Venn diagram model of the overlapping converging data. You always want converging data sets from multiple aspects, multiple spheres, never one sphere. And on average, that will give you the diagnosis. Everybody got this? So a big, long, a tumor, yes, very good. Tumor location. Well, it turns out for all of them, cervical is the most common, but it's preferentially weighted even more for the ganglioglioma, but that's fine, doesn't separate them. Oh, sorry. Look at holocord. Now this series is not that big. N of 27, 15, 25. It's not a bad series, but you can see holocord in this particular series much more common than the other two. Tumoral cyst. All right, look at this, cyst within the tumor. Tumoral means within the tumor. The reactive is the syrinx at the bottom. They can all show syrinx. Tumoral cyst, look how common in the ganglioglioma versus astrocytoma, and particularly ependymoma, relatively rare, 3%, okay? And the daggers, the asterisk was statistically significant. And look at this. Oh yeah, this is what I handed you on a silver platter, as they say, in the very second image after the brain MR. Scoliosis. Almost half of gangliogliomas of spinal have associated scoliosis, only 7% with astro. In this series, none with ependymoma. It doesn't mean it can't happen. That was the giant clue that you probably didn't know. And you're thinking, wait a minute, I'm a brain and spine neurosurgeon. I'm not gonna go to the dark side and start putting in plates and screws and bolts and stuff like kind of become an orthopedic. No. Anyway, I'm gonna stop there. No, it's like, why do I have to know it's scoliosis? Because it's a critical feature. That's why you have to be a complete physician, right? Yes, absolutely. Bone erosion. Check this out. Read remodeling. Let's read remodeling. Almost all, 93% gangliogliomas do this. Maybe half of astros can do it. Ependymomas tend not to do that. They tend not to do it. That was another giant clue. Look, it was the bone, the scoliosis, remodeling. That was giving you the clue at the very beginning. All right, here's the paper. Of course, I put it in the paper. The patients, our patients often go back to their community hospital to receive follow-up treatment. I think it's very important for us as tertiary care pathologists, as specialists, as those who, you don't have to be board certified in neuropathology. If neuropathology, oncologic neuropathology is your love, if that is what you do, you are an expert, and you're certainly an expert an ambassador to your community. And it's up to us as much as we can to share the knowledge and spread the wealth. Okay, so here's the message for this last case, and we're gonna finish up with this message from the last case. Look at this imaging. As I often say, burn this into your brain. You see this again. Put ganglioglioma in there. It might turn out to be ependymoma, pilocytic, glioblastoma, some other else. Put it in there. Hopefully you will never forget it. What's next? The next IDMCC, next conference. Tuesday, 12:15, I will be back in the hot zone, which means on service, which means I cannot do the conference at normal hours because of the conferences at 7 and 8, and then all the frozens. It's going to be another 6 a.m. I'm really looking forward to it. And I hope you are too. All right. If the recording worked and you weren't able to stay, I guess if you weren't able to stay, you can't hear what I'm saying. Anyway, I'll be happy to send you a copy of the recording. You know what? Listen, I like this new model. Instead of using the chat box, I think we're going to have the unmute mute. And here's what I want to do. I want to encourage everyone who did not speak this time to speak on the 15th, if you're in attendance. Just, you could just pop in, just give your diagnosis, remute. I think this would be an excellent habit, and it's going to make it a lot more fun than chat box. Everyone on board? Okay, we'll do that.
Sounds good. Thanks, Dr. Fuller.
Oh, thank you. My pleasure. Everyone have a great weekend. Time to start the weekend. Let's rest and recover.
Thank you,
Bye.
Dr. Fuller.
Thank you.
Bye.
My pleasure. My pleasure. Always.